Hello everyone. Welcome to the second edition of Indian Stents Get Updated. I am Viveka Roy Chaudhary from Express Healthcare. We've been speaking to a lot of interventional cardiologists and all of them have told us that patients are coming to them with cardiac ailments earlier in life and the treatment is more complex. So how are interventional cardiologists coping with this change? How are they training the next generation of interventional cardiologists to read these signs properly? And can they really balance research, teaching as well as clinical practice? To know more about this, we have Dr. Suneil Aggarwal from the UK to tell us more about how he balances these three aspects in his daily life. Hello, Dr. Suneil Aggarwal.
Hello.
Welcome to Express Healthcare. This is a series called Indian Stents Get Updated. It's the second edition. And thank you for speaking to Express Healthcare. You're an interventional cardiologist based in the UK. But you've also been treating patients in India during your postgraduate and now you've moved to the UK. So you have a very diverse patient pool with a diverse genetic background. What are you seeing in terms of trends? Are you seeing patients coming to you with cardiac interventions, needing cardiac interventions earlier on in life? And how does the genetics play into this patient predisposition?
So there's a big difference really between the patient population we see in the UK and the patient population in India. So see, the Indian population generally gets cardiac disease about 10 years earlier than the Western population, and often it's more severe. So, of course, as we see the westernization, if you like, of society, particularly diet and the lack of exercise, you're finding, heart disease is really increasing rapidly in this country. I think, so genetics play a big part. So really the difference we're seeing is that in this country, if people are trying to prevent heart disease, they need to start a lot earlier. And the treatments often are more complex because the disease they have, the pathologies they have are more complex, and the disease, particularly of the arteries, is more diffuse, more spread out. So I think we are seeing now, it was probably inevitable in India, the rapid increase of patients with heart disease. And for that, we need our technology to improve. And also we need to, select the right patients for procedures, make sure we're doing the right things for them early on.
Okay, so it would be fair to say that cardiac treatments are today becoming more complex because the diseases are more complex, the cardiac diseases are more complex, and therefore technologies and techniques have also evolved over the ages to treat the complex diseases which are coming up. How have you seen the evolution of, say, even in heart stents? How have you seen the evolution over the past decade, and what are the new techniques and technologies which you think are going to make a mark in the next decade?
Well, stents have now been around for quite a while, 20 years, more than 20 years. We had bare metal stents first. Those days, in the early days, there was, very thick struts. They were, not that flexible. Over time, the stents become more flexible. Then we had drug-eluting stents where they're coated with a drug. And even those, now we have sort of third generation of those stents. We have the really recent stents which have ultra-thin struts, so they're very thin, very flexible. And as the disease gets more complex, it's important because you have to put longer stents and into more difficult parts of the arteries. And so that's very important. We've also seen, in the last few years, the advent of bioabsorbable stents. Now, the very first generation haven't really been that successful. And the idea of those is that once you put them in a normal stent, the metal will be there forever and you can't remove it. The bioabsorbable stents, in theory, after 2 or 3 years, they will disappear. So the artery is left more like it should have been. And I think that's a promising area, but at the moment, the technology is not quite there. So I think that's something that will come. But, in terms of the metal stents, with the drug coating, that technology is now quite mature. And I think probably the main thing is now choosing the right patients and making sure that the products we have work really well. because you can't assume that if one company makes a stent and then the next one does, that the second one's going to work as well as the first one. It may be better, it may be worse, but we need to do those studies to sort of see which is actually a better stent, or are they equal, which patients are they best in.
So Dr. Aggarwal, you talked about doing studies on stents. What are the most promising studies and randomized clinical trials on stents that you've been part of or that you've recently read about that give you actually the confidence to say that a new stent in the market is doing well and yes, I'll adopt it in my clinical practice?
So I think a very good example of that, especially where in India, is the Talent randomized control trial. So the good thing about that is that, it said, right, we're going to not just select very few patients. We're going to say, how do patients do in general, whether they're having heart attacks, whether they have what they call stable coronary artery disease, any type of patient.
So it's an all-comer trial.
It's an all-comers trial, which is very important. And then it's comparing it against a market-leading stent, the Zion stent. So there is no point doing a study against an old stent and saying, look, we're better. You have to do a study against the latest and the best, and then if you're as good as that, then that's an achievement, that's something good, maybe even better than that. So I think, that's the sort of trial that we should be trying to do.
Okay. And now you've talked about randomized trials and all, but how can you be sure that in your clinical practice the same results are going to be applicable as in the trial?
So I think really the all-comers aspect is very important because, a lot of trials are done where they exclude a large number of patients. And this is one of the biggest problems with trials. They say, right, we're not going to take anyone above the age of 70. Now, in our population in the UK, more than half the patients are above the age of 70. So if you put restrictions like that, we don't know what's going to happen to those groups of patients. So it's really important to have trials where they take all types of patients, or even trials where you select the high-risk patients, those who are more likely to have bleeding problems, those with diabetes, those who generally do worse than the general population. Because if you know that your stent works in that group of patients, then for sure it will work in the less complicated patients.
So how do senior cardiologists like yourself pass on the expertise and the insights that you've gained over the years to the next generation of interventional cardiologists who are today students? How much of your time do you actually spend in academic research, in teaching students? And what is then your advice and tips to younger cardiologists getting into the sector?
So, we spend a lot of our time teaching. Ours is very much a teaching institution, and the majority of cases in our hospital, the first operator is one of the people training. So, it's a practical specialty. You can't learn it from textbooks. Of course, you have to have knowledge, and you have to select your patients properly. That's very important. But how do you learn that? Well, by being there in the clinic, seeing the patients, and then being in the cath lab, doing the procedures. So, training is a very big part of what we do. And research also, at the moment, I know in India particularly, it's not maybe among people who are training something they focus on. In the West, it's sort of a part of our training considered quite important because that is the only way of advancing the specialty. If you just do the same thing now and you do the same thing in 20 years' time, you will be out of date and you'll be doing a disservice to your patient. So I think early on, people training have to have that mindset that they want to learn what's new and be part of developing new things. And that, I think, will improve, the outcomes for patients. And also, I think, professionally, it gives you more satisfaction.
Okay. So now that you've practiced both in India, you've studied in India and then gone to the UK, done your higher studies there, and now you're practicing in the UK. So you have the benefit of seeing the healthcare system in both countries. You've talked about that in India, the research part is not, clinicians are not really trained to do research. So what are the other gaps that you see and that can be kind of filled in and need to be filled in? Any advice to the government or to interventional cardiologists in India?
I feel one of the gaps here is the practical element of the training, because for sure in India people have incredible clinical knowledge and clinical skills, but I think
the volume of patients is also
and the
there.
volume of patients is huge. I think really the focus has to be on the practical elements of the training, and also better understanding of, selecting the patients, understanding the trials out there, because trials, of course, are done with the aim most of the time of selling a product. You have to be able to look at the trial more critically and see, right, this is an all-comer trial. This is more impactful than, say, someone that's selected out a certain group. And I think, when you're armed with that knowledge, you'll be able to read the research findings and critique them better, and that will ultimately lead to, better patient outcomes.
Okay. Dr. Suneil Aggarwal, thank you for speaking to Express Healthcare.
Thank
Lovely
you.
to have you
Thank
with
you
us.
very much.
Thank you. That was Dr. Suneil Aggarwal from the UK talking to us about the need to inculcate a spirit of research. Thank you so much.